ببخشید من میتونم یه سوال دیگه بپرسم؟
Hello everyone and welcome to this webinar about MRD in acute leukemia. I'll be responsible for hosting this presentation today. Thank you for taking time out and being here. We are very excited to have two leukemia experts today. If you have any question during the webinar, please ask your questions in the chat box and then I will ask them at the end of the webinar. And if we have time after presentation, we will be running a live Q&A session. So you can have your microphone on and ask your question as well. Today, our experts will review the clinical utility of MRD in acute leukemia and the importance of MRD assessment pre and post hematopoietic stem cell transplantation. It's a great pleasure for me to introduce and welcome Dr. Farhad Rawandi, who will present clinical utility of measurable residual disease assessment in acute leukemia. Dr. Rawandi is the professor of medicine and chief of section of developmental therapeutic in the Department of Leukemia at the University of Texas, MD Anderson Cancer Center. He has also published numerous research papers on leukemia. Dr. Rawandi, please go ahead.
Good morning. سلام به شما و خیلی متشکر از این دعوت که در این میتینگ پرزنت بکنم. با اجازه شما با انگلیسی حرف میزنم. So good morning or good afternoon to everyone, and I see that you have invitees from a number of countries, so I think it is obviously best for me to speak in English. As you heard, I'm going to talk about the utility of using or assessing measurable, or what was used to be known as minimal residual disease in patients with acute leukemia, and I'm actually going to really focus on acute myeloid leukemia. These are my disclosures. So the questions to consider are: what are the available assays? What are the best assays and reliable assays? Is there a need for standardization of these assays? And also, most importantly, if you find measurable residual disease, is there a way to deal with it and essentially get rid of it? And there are now a number of potential options that can be used. This is from the European Leukemia Net guidelines paper that was published a couple of years ago. And actually there is an updated version which I'm part of, is coming up fairly soon. And you can see there are a different number of assays that you can use to assess residual disease, residual leukemia. And by this, what we mean is that historically, we have relied on morphology and an expert pathologist to determine whether a patient is in complete remission or not. And that looks only at limited number of cells, but obviously there are other assays that we can use, including even cytogenetics, FISH, and more importantly, flow cytometry, PCR, and NGS. Now, with using cytogenetics, and you all know that when we do cytogenetics analysis in a bone marrow specimen, we only look at 20 to 30 metaphases. So this is not a highly sensitive assay, but our group, as well as others, have shown that even using cytogenetics, if your patient is in complete remission, but still has detectable cytogenetic abnormalities in their marrow, they have a significantly worse relapse-free and overall survival. So again, even measurable residual disease using a very insensitive assay like cytogenetics can be very useful to predict outcome. Of course, now we have more sensitive assays such as reverse transcriptase Pcr And this obviously looks at present molecular or abnormalities or fusion transcripts. And of course, they have to be present. And if you look at this slide from David Grimwade from a few years ago, these molecular abnormalities and fusion transcripts are much more common in the younger patients. And when you get to the group above the age of 50 and 60, a majority of patients don't have these abnormalities. So it's useful, but not universally available. Of course, APL is the gold standard disease where detecting residual disease has been important in terms of prognostication. This is particularly in the era of before the introduction of arsenic trioxide. These data are really from the era of ATRA plus chemotherapy. I know in Iran you use arsenic trioxide, but with ATRA and chemotherapy, it was clear that if you had residual disease, you were much, much more likely to relapse. And this was obviously done by PCR for PML-RAR alpha. Dr. Greenwade in the UK did this other publication, very important publication, showing that if you monitor for persistent residual disease or recurrent residual disease by PCR for PML-RAR alpha, and if you detect it and then use arsenic trioxide, you can clearly prevent overt relapse and actually improve outcomes. So you can use PCR for monitoring MRD in APL, although, as I mentioned, with the ATRA and arsenic regimen, this is now becoming less and less important because the majority, in fact, almost all of the patients achieve complete molecular remission and remain in complete molecular remission. Other leukemias, such as core binding factor leukemias, inversion 16 and A21, also have detectable fusion transcripts. And these have also been used for assessing residual disease. This is in the case of A21, again from data from UK, showing that if you can detect residual disease at the end of induction and consolidation, you're much more likely to relapse and you have a worse outcome. Of course, with these abnormalities, you're only talking about a section of AML patients. So APL in about 10% of AML, core binding factor leukemias also account for about 10%. So this is not universally applicable, obviously. There are other molecular findings that you can detect with PCR. So for example, NPM1 mutations occur in about 30% of AML and about half of all normal karyotype AML. And this data, again, from David Greenwade group in the UK, showed that using peripheral blood monitoring for NPM1 mutations, the likelihood of relapse was much higher if you were positive after 2 courses of induction for persistent NPM1 mutation, obviously in a patient who was NPM1 mutated at the onset. So if you have an NPM1 mutation, you can clearly use NPM1 as a measure of residual disease in this study in peripheral blood, but also in bone marrow exam. Flow cytometry, however, is much more universally applicable because you can use that in over 95% of AML patients. And what it detects is what we call leukemia-associated immunophenotype, which is aberrant expression of markers that shouldn't be on leukemia AML cells or normal cells, aberrant levels of antigens or co-expression of early and late antigens where they shouldn't be coexisting. So this is a way that the flow cytometry experts can detect residual aberrant or leukemic cells. Nowadays, many centers use compared to normal assays. So they look at the cells that are remaining in the bone marrow and they compare their antigenic expression to normal. But you can actually use a combination of leukemia-associated immunophenotype and compare to normal assay. This is not a new thing. You can see this paper is from 1997 from the Spanish group, clearly showing that if using, actually this was only with a 4-color flow cytometry, they showed that using even a rudimentary 4-color flow, you can actually detect leukemia cells, and if they were present, the outcome was median relapse-free survival was significantly worse. The pediatricians picked this up and have been actually using this a lot in the US. The Children Oncology Group has been stratifying their patients and their treatments based on flow MRD assay, but also the adults have obviously started developing this. Just want to show you this study that we now started, I think about over 10 years ago at my institution, where we said, well, we're going to try to have some sort of maintenance therapy for AML. And the idea was decitabine could be a useful drug for maintenance therapy. So patients who were in remission after induction and consolidation would be randomized to either receive decitabine or one of the 3 other options: low-dose cytarabine, continuous chemotherapy, or just observation. I think the main reason I'm showing these slides is because this was the most important message we got from that study, that we did minimal residual disease assessment by flow cytometry using a 6-color flow panel at that time. And anybody who were entered on the study had this assessment. And you can see here, patients who were positive by flow for MRD had a significantly worse event-free, and actually I'm not showing it, but also overall survival, highly significant. And in fact, in multivariate analysis, positive flow cytometry was the only highly significant predictor of outcome. The use of decitabine was not. So it just shows you that the importance or strength of flow cytometry MRD in predicting outcome. Of course, this has now been done in by many groups. This is the Dutch Hoven group. On the left side of the panel, you see at the top, after first induction, C after the second induction, and E after the consolidation. And you can see patients who are positive for MRD by flow cytometry have a significantly higher likelihood of relapse. On the right, it just shows you that this is applicable to favorable, intermediate, and adverse cytogenetic subgroups. So if you are using flow and it is positive after induction or consolidation, this highly predicts for relapse and even worse survival. This is a study that we did in our group, and this is with the more intensive higher dose cytarabine induction. You can see on the slides on the left, at the end of induction, if you were positive for flow MRD, you had a much shorter relapse-free survival. In the middle is it's during consolidation, and on the right is at the end of consolidation. So clearly, if you remain MRD positive, the red lines, at any time during the course of therapy, you are much more likely to relapse, and at the bottom is this is associated with a worse survival as well in the bottom 3 curves. This is a study. The studies that I've shown you so far have been mainly in the younger AML patients younger than 60. So this is a study by Sylvie Freeman from the UK in older patients older than 60 who received the 3+7 type chemotherapy. And again, she did show that if you are MRD positive after course 1, and in other slides that I'm not showing, after course consolidation, you are much more likely to relapse on the left, and this is associated with worse overall survival on the right. So even in the older AML patients, achieving MRD negativity is important. This is another study by Sylvie Freeman, and again showing this is in a younger population of patients from the MRC group or the UK group, showing that I think the most important part of the slide I want you to focus is that if you achieve CR or CRI, and are MRD negative by flow, that's the blue line, you have the best outcome. But most importantly, if you are CR or CRI and MRD positive, the yellow line, your outcome is almost identical to if you are partial response or PR in the gray line. So achieving MRD negativity is essentially much more important than achieving a full complete remission. So if you're CRI MRD negative, you do better than if you're CR MRD positive. Now, other assays are now being used in the more recent years. Now, with the advent of next generation sequencing, we can actually look at mutations that are present at the time of diagnosis and see if they are cleared by the chemotherapy that you give the patient. So this is MRD assessment using next generation sequencing or mutation clearance. And this is the first study that was published on this, essentially showing that in the top two slides that patients who become MRD negative by next generation sequencing, essentially if you clear the mutations, you have better disease-free or event-free and overall survival. At the bottom, they only looked at the specific intermediate risk population. And of course, this was also true in that population. So you can use mutation clearance for MRD assessment. And the more important study of this was published by the Dutch group in the New England Journal of Medicine now 2 years ago. It was actually an ASH plenary presentation as well. And you can see here, they again looked at mutations at the time of diagnosis. The blue bars at the top are the mutations that were present at the diagnosis. And then when the patients achieve remission, they also look for these mutations. And you can see the number of these mutations persist, the red bars. However, it's important to note at the bottom part of the slide that 3 of these mutations, the DNMT3A, TET2, and ASXL1, are persistent at high levels at the time of remission. You know, you can see at the y-axis that they are present at levels of up to about 50%. So essentially, these 3 don't seem to be cleared. And this is because these are what we consider as CHIP mutations or clonal hematopoiesis of indeterminate potential mutations. They showed that if you forget about those 3, the DTA or DNMT3A, TET2, and ASXL1, if you look at the other mutations, if you clear them, this is associated with much better relapse-free and overall survival. In fact, on multivariate analysis, the clearance of DTA mutations at the time of CR, so clearing all mutations except for DNMT3A, TET2, and ASXL, was the most important predictor of relapse, relapse-free survival, and overall survival. So yes, we can use next-generation sequencing for an assay for measurable residual disease at the time of remission. Now, you can actually combine these assays. In this same study, they did have a cohort of patients that they did have both flow results and NGS results. And you can see here, clearly, the patients who were both NGS negative and multiparameter flow cytometry negative, the blue line at the bottom, had the best outcome, the lowest likelihood of relapse. Whereas the patients who were both positive by NGS and flow, the purple line at the top, they were most likely to relapse. Now, if you were positive by either assay, you were in between. You can see that. So actually, we can start using these assays to become more confident about our MRD negativity. This is a study that we just got published in JAMA Oncology, actually a week ago, roughly, or less than a week ago, which is a meta-analysis of all the relevant publications since about 2000, looking at measurable residual disease in AML. And this was 81 publications with over 11,000 patients. And you can see here clearly that if you become MRD negative, your disease-free survival and overall survival is significantly better than the patients who were MRD positive. So I think what we can say and what I like to believe is that MRD is a biomarker which can be a surrogate endpoint for outcome in AML and also can be used for developing new drugs. Now, as I mentioned, the most important thing about MRD is that if you is positive, you do have a way of dealing with it. Of course, there are a number of agents that are being developed for this purpose. You probably all have heard of the oral azacitidine, which was just recently approved in the US for maintenance therapy in AML. There will be data at this year's ASH looking at the flow cytometry or MRD assay in that study. But clearly, hypomethylating agents like azacitidine or decitabine can potentially be useful agents for eradicating MRD. And also you see on the list a number of other potential agents that we can use to eradicate MRD and for using in maintenance. What about allogeneic stem cell transplant? Now, this is data from Fred Hutchison that looked at patients who were MRD positive and MRD negative prior to transplant. I'm not going to go over this data into too much detail because I believe Dr. Kebriai is going to be talking about this. But you can see from this data that MRD positivity was associated with worse disease-free and overall survival. And this was mainly because of higher incidence of relapse in the bottom part of the slide and not because of non-relapsed mortality. And in another publication, they showed that any level of MRD by flow prior to transplant was associated with worse outcomes. The dark black line is for patients who were completely negative, and the three other lines are different levels of MRD positivity. So even a low level of MRD was associated with a higher likelihood of relapse and worse survival. And this was not because of worse non-relapse mortality. There is a recent publication from Chris Horrigan in the NIH looking at allogeneic stem cell transplant. Again, I'm not going to say too much about this because Dr. Kebriai will go over it, but I think the message of the study was that if you have MRD at the time of or prior to transplant, the best way to deal with it is using a myeloablative regimen rather than a reduced intensity conditioning. And again, Dr. Kebriai will expand on this. Other ways, as I mentioned, hypomethylating agents. This study from Uwe Platzbecker in Germany used the MRD and used the azacitidine to try to clear MRD. So they did show that using azacitidine, they could clear MRD in about 58% of the patients they were treating. 42% patients did not clear, and you can see the patients they did clear did better than the patients they did not in terms of relapse-free and overall survival. This is the other study that I mentioned to you about maintenance using oral azacitidine that hopefully will be published very soon. And here, again, using oral azacitidine as maintenance, they did show a significant improvement in survival. And this was true for patients who were MRD positive at the time of enrollment, as well as the ones who were MRD negative. So again, I will refer you to this year's ASH. There is data on flow cytometry MRD in this study. Finally, there are other potential agents that are in development for MRD clearance. You all probably know, I'm sure you all know about blinatumomab, which is an agent we use in acute lymphoblastic leukemia as a bispecific antibody. And then there's a number of potential bispecific antibodies that are being developed for treating potentially MRD in AML. So with that, I would like to conclude and say that I think assessing MRD is here to stay. There are different assays. I think the more important ones are now flow and NGS and PCR. Their potential the need for standardization of these techniques is being discussed, and I think it is probably important because flow is a very complex technique that does require a very experienced flow cytometrist. And also there are different strategies that are now being evaluated for eradicating MRD, and I believe these will lead to improvement in outcome in patients with AML. And with that, I thank you for your attention.
Thank you very much, Dr. Ravandi. I hope you all enjoyed this amazing presentation. Our next speaker is Dr. Partov Kebriai. Good morning and very welcome to MRD webinar. It's a great pleasure to have you with us today. Dr. Kebriai, who will be giving us a presentation on the importance of MRD assessment in acute leukemia, pre- and post-hematopoietic stem cell transplantation. Is the professor of medicine at Department of Stem Cell Transplant, Division of Cancer Medicine at the University of Texas, MD Anderson Cancer Center. Dr. Kebriai, please go ahead.
سلام، خیلی از بابت دعوتتون تشکر میکنم. And similarly, as this is an international conference, I will continue the rest of my talk in English. So again, many thanks to the organizers for this great webinar. I will be speaking on the impact of measurable residual disease, specifically prior to stem cell transplantation in patients with acute lymphoblastic and myeloid leukemia. So I will not spend much time on the definition, techniques, and significance of MRD, as the previous speaker just eloquently did so, but again, really speak to the significance of MRD prior to transplant, and most importantly, interventions that we can use then to reduce the risk for relapse. But to remind the audience, MRD would be really talking about the residual cells that are present in a patient who by standard definition would be considered to be incomplete.
Please show a slide.
Hello?
Favorite slides?
You can't see the slides? Can you see my slides?
No.
Can you see the slides?
No. We can see your slides. Thank you very much.
Can you see the slides?
Yeah, thank you.
Okay. Yes? Okay, we can see the slides?
Yes.
Okay, so this is a nice cartoon that graphically shows what we mean by when we say MRD. The reason I think the field has moved from moving from the term minimal residual disease to measurable residual disease is, with using next generation sequencing techniques, generally we're able to detect up to 1 in 10 to the 7th cells, and that's really not reaching the floor of what we would consider to be truly negative, MRD negative. And so I think this is just a reminder of what MRD really means, and that the levels are constantly changing as we develop more sensitive techniques. And again, these various techniques have been previously reviewed, but conventional cytogenetics, which we used 10, 15 years ago, had a sensitivity of just 1 in 100 cells. And now we're using techniques that routinely are giving us sensitivity as 1 to the 10 to the 7th. So again, underscoring the importance of this very powerful tool that we have now at our disposal. When we talk about the significance of MRD, we also have to remember at which time point in the treatment plan of the patient we're using MRD. When we use MRD early in therapy, It is a tool that really may allow us to either intensify or decrease the intensity of the therapy, whereas when we talk about MRD at later time points, for instance, prior to stem cell transplant, it really is underscoring or it's a surrogate of subsequent relapse. And just to remind the audience that all of the studies in pediatric ALL really started to look at the impact of MRD almost 2 decades ago. Again, the significance of MRD is context dependent, as I just said, in terms of the timing in the patient's treatment history, and then, of course, dependent on the technique that's used, and possibly on the disease and disease stage of the patient. So the bulk of the talk, again, will look at the MRD prior to transplant. And this table is just a summary of selected studies in patients with acute lymphoblastic leukemia where MRD was measured by flow or PCR. And most of the studies measuring MRD by PCR were patients having Ph-positive ALL. But really, I'd like to emphasize that when you look at when these patients were measured for MRD across the board, the patients who are MRD positive had a significantly higher rate for subsequent relapse following transplant. And this is irrespective of the measure, of the form of MRD measurement. And the difference is almost twofold in some studies. What about more sensitive techniques such as next-generation sequencing? This is a nice study by Pulsifer and colleagues looking at kids that were treated with BALL on the cooperative oncology group, and they looked at the impact of MRD prior to transplant using both next-generation sequencing and multi-parameter flow. The NGS method was using immune globulin variable chain rearrangement, molecular techniques, and flow was 6-color flow in this study. All patients received a myeloablative radiation-based conditioning, and all the patients were either in first or second remission. And again, this study really nicely showed the impact of MRD both by flow and NGS. In panel A, you can see the significant higher rate for relapse using NGS MRD technique. So those who were MRD positive in the dashed red line had a significantly higher rate for relapse. And importantly, something to think about, those that were MRD negative, actually there was no relapse, not a single relapse. When we look at survival, there was 1 death in the NGS MRD negative group. Again, survival for the NGS MRD positive group significantly worse. And then panel C is quite interesting because they took those patients that were MRD positive by next generation sequencing, a small number, only 19 patients. But interestingly, and not surprisingly, what they showed is those patients who developed acute graft versus host disease had a significantly lower rate for relapse compared to the patients who did not, illustrating very nicely the graft versus leukemia effect that we hope for when we do a transplant. So in summary, NGS is powerful, GVL does exist in ALL, and it bears to question in the fact, since no one in the MRD negative group relapsed, do we need to transplant a subset of these patients? And then looking at NGS versus multi-parameter flow, this was reviewed in the prior presentation as well. Not surprisingly, you can see that NGS is more sensitive than multi-parameter flow. So in the group that was MRD negative by multi-parameter flow, there was still a 20% risk for relapse. There have been now several meta-analyses looking at these single center and phase 2 trials using MRD. This is a meta-analysis by Shen and colleagues where they looked at multiple studies that were reported in several large databases looking at MRD prior to transplant in kids and adults who received a transplant. And you can see all of the exclusions. They ended up with 21 studies. But the take home here, not surprising again, is that in those patients who were MRD positive by a variety of techniques, those patients had a significantly higher rate of relapse, more than threefold by hazard ratio, you can see, significantly worse relapse-free survival, and significantly worse overall survival with a hazard ratio almost reaching 2. Again, no association, however, with MRD and non-relapsed mortality. What about MRD prior to transplant in acute myeloid leukemia? We did a study at MD Anderson where we looked at about 150 of our adults who underwent transplantation with a myeloablative conditioning regimen between 2012 and 2015. We used 8-color flow to assess MRD, and risk stratification was based on the European Leukemia Net classification. Based on this method, the multi-parameter flow method, about a third of our patients were MRD positive prior to transplant, and not surprisingly, this group was significantly older, had adverse cytogenetics, and required more therapy to achieve remission. And again, what we see, MRD positive demarcated by the red line, MRD negative demarcated by the blue line. You can see that the presence of MRD prior to transplant significantly increased the risk for relapse, and panel B significantly decreased relapse-free survival and significantly decreased overall survival. Importantly, when we looked at MRD versus ELN risk stratification based on cytogenetics, in the patients that were classified as having adverse risk by ELN criteria, whether patients were MRD negative or positive, there wasn't a significant difference. But when we looked at the intermediate group, those patients who were MRD positive did significantly worse compared to MRD negative. And I think this nicely illustrates that MRD is one tool that, if we use in conjunction with other existing tools, gives us an even more powerful form to try to discriminate amongst patients. The Fred Hutch group did a similar analysis looking at MRD prior to transplant in AML. They had about 300 patients who underwent transplant either in first or second remission, again with a myeloablative conditioning regimen. They used 10-color flow, and about 23% of the patients were MRD positive prior to transplant. Now, in this study, what's nice is they're looking at MRD versus traditional disease stage classification. So the black line represents those patients who are in first remission but MRD negative. The red line demonstrates those who are in first remission but MRD positive. Green is second remission patients MRD negative, and blue is second remission MRD positive. And what you see in panel A is that the overall survival of patients is best for those who are MRD negative, whether they are in first remission or second remission. Similar pattern or trend when we look at relapse-free survival. So those patients who are MRD negative, irrespective of disease stage, do better. When you look at relapse, again, those who are MRD positive, irrespective of stage, have a significantly higher rate for relapse. And when we look at non-relapsed mortality, this again illustrates what was shown in the meta-analysis. There really is not an association between non-relapsed mortality and MRD. This was a similar meta-analysis as we saw for the ALL patients, looking at MRD prior to transplant in patients with AML undergoing transplant. And again, Medline MBase were used, 19 studies ultimately included, and compared to MRD negative patients, those who were MRD positive had higher risk for relapse and ultimately leukemia-free survival. Again, no association with non-relapse mortality. And in this meta-analysis, adverse cytogenetics was not an independent risk factor for death or relapse, in contrast to MRD. So if we know that MRD prior to transplant predicts for relapse, what can we do about it? So I'm going to focus on acute lymphoblastic leukemia because, as this group knows well, several very powerful agents have been in the more recent past have been approved. Blinatumomab, which was mentioned in the prior study, a bispecific T-cell engager directed against CD19. And what's powerful about blinatumomab is that it affects a very high MRD negativity rate with very little cytotoxicity. When we look at the randomized Tower study, blinatumomab versus traditional chemotherapy or standard chemotherapy in those patients with refractory relapse B-ALL, again, we see that those patients receiving blinatumomab had a significantly higher CR rate, importantly, a significantly higher MRD negativity rate, which then allowed a significantly higher number of patients to go to transplant. I think what I want to just emphasize in this figure is that transplant was improved whether patients had blin or standard of care, but transplant, and in those who are MRD negative, resulted in the best overall survival. Inotuzumab is an antibody, again, an antibody therapy directed this time against CD22. It's bound to calicheamycin. And again, as a single agent, a very powerful drug, resulting in overall response rates of up to 80%. You can see the MRD negativity rates as well. In inotuzumab, the only limitation I would say is that because it's bound to calicheamycin, there is evidence for hepatic toxicity, specifically if we're using this agent prior to transplant, veno-occlusive disease. This just shows that overall survival could be achieved in patients with refractory leukemia with a survival of up to 50% at those who achieved remission and went on to subsequent transplant. But just a note on the veno-occlusive disease rates, there was a VOD rate of up to 20% in patients. So we do need to be cognizant of this toxicity. Patients who received a dual alkylating myeloablative conditioning regimen had a significantly higher risk for VOD. Those patients who showed any evidence for liver dysfunction going into transplant had a higher rate of VOD, and those patients, not surprisingly, who had prior history of liver disease had higher rates for VOD. So at our institution, we do use VOD as a means to eradicate MRD, but we subsequently then modulate the transplant conditioning regimen and take other supportive measures such as using ursodiol, not using other hepatotoxic agents peri-transplant to minimize the risk for subsequent VOD. And I include this table of CAR therapies really to be complete with regards to listing effective agents for ALL. But as we all know, although CARs can result in very high and importantly very deep, meaning MRD negative response rates, the limitation is one, it is associated with very serious toxicity in the form of cytokine release and neurotoxicity in about a third of patients. But I would say even more importantly, it's associated with almost prohibitive cost. So I'm not sure that CARs would be the first agent I would go to try to eradicate MRD prior to transplant, but it is an option for those patients who have exhausted all other therapies. What about modulating the transplant conditioning regimen in those patients who are MRD positive pre-transplant? Again, this was alluded to in the prior talk. This is a very nice study that was done by Horrigan and colleagues where they took blood samples from 190 patients that were enrolled on the Center for International Blood and Marrow Transplant Registry. This was a randomized study looking at reduced intensity conditioning versus myeloablative conditioning in adults undergoing transplant for AML. All patients were in complete remission. They used essentially next generation sequencing, very deep molecular techniques to assess, very sensitive molecular techniques to assess for MRD. And by this method, they noted that about a third of patients were MRD negative. And the take home here is that in those patients who are MRD negative, there was no difference in relapse and survival if patients received either a myeloablative or reduced intensity conditioning regimen. That's shown in panel B, and it's the teal dashed line and the red dashed line. But if you look at patients who were MRD positive, there was a significant benefit to using a myeloablative conditioning regimen. I think the other take home here, though, is still to remember that there is significantly less non-relapse mortality with the use of reduced intensity conditioning regimen. That's shown in panel A. And when we look at relapse in panel B, however, this decrease in non-relapse mortality is at the expense of higher relapse. So in panel B, the pink dashed line is those patients who are MRD positive receiving a reduced intensity conditioning regimen. The dashed red is those who are MRD negative having a reduced intensity conditioning. So even in that group, there's still a higher risk for relapse. But again, that's what we pay for using non-relapse, for using RIC conditioning. And then finally, what about maintenance therapies? If you have a patient that's MRD coming into transplant, will maintenance abrogate the risk for relapse? And I think there are many studies ongoing, many in AML looking at transplant and looking at maintenance following transplant. I would say that these are all studies that are continuing to be under investigation. We don't yet have a very clear conclusion on that, although studies suggest that perhaps maintenance may be beneficial. I think in the maintenance in the transplant setting, most of our data thus far would come in from patients with pH-positive ALL receiving TKIs or tyrosine kinase inhibitors post-transplant. And in aggregate, those studies do show a benefit for maintenance therapy. But I would say that it's important to look at the impact of maintenance within the context of MRD prior to transplant, and I don't think we've answered that quite yet. So in conclusion, I would say both talks now, I hope, have convinced you that MRD is a very powerful tool. It's an overarching way of looking at both patient factors, disease factors, and treatment factors, and allowing us to either early on intensify or de-intensify our therapy. It's critical that we standardize methods to assess for MRD, and I think we are doing that. MRD prior to transplant definitely predicts for relapse, and we need to continue to work on optimizing our interventions, or optimizing our ways to intervene to reduce this risk for relapse. And with that, I thank you for your attention.
Thank you very much, Dr. Kebriai. I hope you all enjoyed this excellent presentation. Thank you again. In the next session, we have two case presentation and discussion. The first one presented by Mohammad Waizi. Mohammad Waizi is a hematologist, oncologist, is associated professor at TUMS, Tehran University of Medical Sciences. He is active faculty member of Hematology, Oncology, and Stem Cell Transplant Research Center. Please, Dr. Waizi.
Was there microphone? Hello, everybody. I'm presenting a patient that was it? با مشو. Hello, everybody. Good morning and good afternoon. I'm presenting a patient that he is an 18 years old young man that he presented with malaise, weakness, and petechiae. On CBC, he had leukocytosis, anemia, and profound thrombocytopenia. Ultrasound showed mild splenomegaly and multiple lymph node in para-aorta and portohepatis. Bone marrow aspiration and biopsy revealed acute lymphoblastic leukemia, per-B cell ALL. Cytogenetic study showed just 922 translocation and with no other abnormality. BCR-ABL by RT-PCR was positive. So, of course, these are documents. And BCR-ABL fusion transcript was P190. And so treatment was started with weekly vincristine and dexamethasone and imatinib for just 400 milligram per day because he didn't tolerate higher doses of imatinib. CSF was negative, but intrathecal MTX as prophylaxis was done. After 28 days after starting chemotherapy, bone marrow aspiration biopsy revealed that it is in complete remission, and BCR-ABL ratio by QRT-PCR was 0.07%, and flow cytometry revealed that MRD was 0.05%. This is MRD by flow cytometry. At this time, these are my questions. I ask Dr. Rostami how to interpret these values. What's your interpretation about these values? About positive or negative? Do you think about these results, please?
Okay. In this patient, because at CR, BCR-ABL ratio to ABL is less than 0.1%, the patient achieved MMR. However, previous study on Philadelphia positive ALL patient treated with first-line chemotherapy plus a tyrosine kinase inhibitor have shown that MRD status at 3 months had better discrimination for OS and RFS than did MRD status at CR. And patients who achieved CMR by 3 months have excellent long-term survival, which is independent of any baseline factors or TKI received. And which test is better for this patient? In Philadelphia positive ALL, BCR-ABL1 mRNA transcript detection by RT-PCR is the preferred MRD marker.
Thank you so much. Is there any comment from dear panelists, other dear panelists? Dr. Yagmi, please.
Dr. Kebrier, thank you for your wonderful presentation. I have one question from you before I answer the question of Dr. Boise. I would like to know if the international scale that presented by EAC for CML patient, it also works for the Philadelphia positive ALL, or you have a different standardization for E1, A2 fusion transcript in Philadelphia positive ALL?
I would say that we're not currently discriminating between looking at P190 versus P210, that we're using the same scale.
I think the international scale presented for B3A2 and B2A2, but Euro MRD are standardization, the E1A2 with the different cutoff that they joined EAC to identify another cutoff for PH plus ALL, and I would like to see if you are also using the same international scale for this patient or other things you may use.
The same international scale.
Thank you. And the other question is that,
can I just say the international scale was developed for CML and really involves the P210. That, you know, the standardization of international scale is essentially based on the P210 BCR-ABL, and when you are, the more recent publications on BCR-ABL in Ph positive ALL, the P190 really just used log reduction, not based on the international scale.
Does that make sense? Reduction you consider as a complete molecular response, or for ALL PH plus, which log reduction you considered for?
Well,
ALL
like anything else, more than 4.5 log reduction, if you see what I mean, or the undetectable essentially.
And do you believe that multimodality techniques for MRD assessment is better than one technique? Because as you presented for the NGS and flow cytometry can better discriminate the patients, and maybe if we use the different techniques, for example, the NGS or PCR, FISH, flow cytometry, and different modalities, it may help that we can find the different subpopulation of AML patients. Because as I remember, you presented something in MD Anderson that some patients that are flow negative, they were FISH positive. And by imaging, you show that this positive FISH result was in differentiated cells, that they cannot predict the relapse. So I would like to know that if this multimodality techniques helps for better predict the outcome or not. From Dr. Ravandi. We disconnected from Dr. Ravandi. If he has been disconnected, Dr. Kebriai, if you can answer my question.
Yeah, so while we're trying to reconnect him, you're correct that there are some cases where there is a discrepancy, and it's unexpected because the traditionally more sensitive technique, for instance, the PCR will be negative while our flow is positive. And I think when you have cases like this, it is helpful to use multimodality techniques because there are times our pathologists tell us that our flow is picking up perhaps not an aberrant leukemic cell. So I always think that multimodality helps, and there are cases where it's very difficult to tell a malignant clone from a hematogone, and that's where it's helpful. Does that answer your question?
Yes, you answered. Thank you.
Thank you. Another question is, how does MRD predict the outcome? Level of MRD, time point, and source so that we check MRD. Would you please help us? Professor Ravandi is disconnected. Professor Kebraye.
Sure. So I omitted a slide. There was a study from St. Jude's in children with ALL, and there's many studies now that the level of MRD is associated with risk. So if you have, very low MRD compared to very high MRD, there is a subsequent increased risk for relapse. So I think that the level of MRD is predictive. With regards to timing, I think that as you just talked about in this particular case, looking at MRD at day 20.
Which of these options are better to as consolidation? TKI plus chemo, autologous stem cell transplantation, or allogeneic? If you choose allogeneic, match-related, haplo, or other options, please help us. Professor Kebraye, thank you.
I didn't know.
Dr. Ravandi is disconnected, and we have to.
Of course. So in this patient, the patient is very young, and the patient received actually a relatively very low intensity induction with vincristine and dexamethasone and imatinib. So if the patient is MRD positive at day 28, the first
are you agree with this chemotherapy less intensive versus hyper-CVAD that you use in MD Anderson? According to graph 2005 trial. Do you agree with this chemotherapy?
So I would say that at our center, we are not using this less intense therapy. We are still using hyper-CVAD. I would say that, and with the hyper-CVAD and a TKI, now we're using ponatinib, almost 90% of our patients are MRD negative by day 28. So I think what this shows you is that in this particular case, you need to intensify the therapy because the patient is still MRD positive. If with intensification, the patient becomes MRD negative, that to me is the real question. Do you then consolidate with transplant or continued chemotherapy? And I would say that once whatever we do now needs to be intensified, and if you can get the patient MRD negative, then it's reasonable to continue with chemotherapy and TKI only based on the pediatric literature for Ph-positive ALL and first remission.
And if MRD was positive, you proceed the patient to allogeneic stem cell transplantation.
I do versus autologous transplantation. I know there are several studies in Ph-positive ALL where if the patient is MRD negative, autologous stem cell transplantation appears, in these studies looks as good as allogeneic. I think in the absence of a randomized study, remember all the old studies that randomized between autologous and allogeneic, allogeneic was clearly better. And so, and the patient is only 18. So I would still recommend an allogeneic transplant over autologous.
The patient, our patient didn't have any sibling, and we have to go to search for match-related or haploidentical. What's your opinion about match unrelated or haplo in
Yeah.
complete response one?
Yeah. You know, again, in registry, within the limitations of a registry analysis, we just completed one from the CIBMTR that will be presented at ASH. Haplo did equivalently to MUD. And so I think for sure when we talk about alternative donors, so if we don't have a matched donor, haplo versus cord, I think in my mind now it's very easy to say haplo. When we talk about haplo versus MUD, given how much easier it is to procure the haplo, I think the haplo is a very reasonable option, especially if you need to go quickly or there are difficulties in procuring the MUD. I have to tell you though, at MD Anderson, our preference is still MUD over haplo if we can get the MUD very easily or quickly.
Recently, a Chinese study that published that Phi positive, MRD positive ALL, the result of haploidentical was better than MUD, match unrelated donor. What's your opinion?
Yeah, I was the Chinese study, I can't remember, was it prospectively assessed, MUD versus haplo?
I think it was randomized. 268 patients that randomized with the two group.
Yeah, no, I think that's very compelling. I think it is compelling, but I have to tell you that I have equipoise between MUD and haplo, and the reason that I would still select the MUD over haplo is really based on the bulk of data and the absence of, you know, multiple large prospective randomized studies. I think it would be nice actually to do a meta-analysis on this question.
Thank you so much. I will continue. 2 months later, this patient developed with firm reddish swelling in the left temporal parietal area of his skull. A skeletal ultrasonography showed no abnormality. Chest and abdominal pelvic CT scan was normal. This is image. The biopsy was done, and dermal lymphocyte infiltration consisted of with metastatic lesion, and he CSF was negative. Was still negative. Bone marrow was negative, and due to pathology report and no involvement of other sites, he underwent 15 fractions of radiotherapy with good response. Imatinib was continued.
Present time. She was referred to hematologist due to thrombocytopenia during routine follow-up. Her CBC showed mild anemia and thrombocytopenia. We examined the peripheral blood smear, and some myeloblasts were seen. Based on her bone marrow aspiration, morphology, and flow cytometry, the diagnosis was AML-M2. Cytogenetic study demonstrated deletion of chromosome X and translocation between chromosome 8 and chromosome 21. We also conducted HLA typing for her, and we found an HLA matched sibling donor for her, who was her sister living in Canada. Based on the cytogenetic results, we approached to her as a favorable risk de novo AML. The treatment initiated with 7+3 regimen, and we achieved complete hematologic remission 28 days after. Then she received 4 cycles of high-dose RSC. During and at the end of the treatment, MRD assessment by RUNX1, RUNX1T1, real-time quantitative RT-PCR in her peripheral blood was conducted. You can notice the change of RUNX1, RUNX1T1 by RT-PCR during and after treatment in this diagram. As you see, after second course of high-dose RSC, the MRD was 0.0001. Now, I would like to ask Professor Rawandi, how would you have managed the patient with a near 4-log reduction in MRD at such a situation?
In core binding factor leukemias, I think there is a high degree of evidence in using meta-analysis and randomized studies and about 2 decades of studies that have shown the use of gemtuzumab ozogamicin in induction and consolidation is highly beneficial. So I don't know if you have the gemtuzumab available in Tehran, but I highly recommend using gemtuzumab for your induction. You may say you don't have the result of the inversion 16 or 821 analysis, on day 1 of 3+7, but I think you can add gemtuzumab later, maybe day 4 or day 7. A very small dose. We only used 3 milligrams per herd, which was the British dose. There is the French alpha dose, where they gave everyone a fractionated dose of 3 milligrams days 1, 4, and 7. But again, I think only 3 milligrams per meter squared is sufficient. We do also see in my institution, occasionally I get referred the patient who is treated outside with 3+7 and comes in remission, and just like your patient has very good reduction, but even then I add a dose of gemtuzumab to their high-dose RSC consolidation. Overall, you need only a couple of doses, so maybe if you give it in your first consolidation, I would then just give it on the 3rd consolidation as well. The gemtuzumab is associated with the prolonged thrombocytopenia, so if you give it to a patient and your counts don't recover fast, that is part of gemtuzumab, but I think, at least in our hands, that has been acceptable. The other thing that obviously in your patient is going to happen, looking at these curves, is relapse. This patient is very likely to relapse. So you need to consider some form of preemptive therapy, and there is no standard preemptive therapy. So you could do one of two things. You could, again, if you have gemtuzumab, you could consider giving a dose of gemtuzumab, ozogamicin, and see what happens to the MRD. or you can consider using hypomethylating agents like decitabine. Now, again, that is not based on any published data. There is no literature to support that. You also need to obviously know that gemtuzumab does have a risk of veno-occlusive disease of the liver, especially if you decide to go to transplant after. If you just go to transplant, based on all the available literature, even after transplant, this patient is likely to relapse.
Professor, unfortunately, we don't have a GO available, so we decided to continue high-dose RSC for another 2 cycles. And at the end of our treatment, the MRD became undetectable, and we achieved a complete hematologic, complete molecular response. 2 months later, on follow-up, she experienced a molecular relapse, and MRD at this time was 0.008, and CBC at this time was normal. And a month later, molecular progression occurred, and as you see, the MRD was 0.13. So we started azacitidine and planned for allo-HSCT. However, several problems were faced during the COVID-19 pandemic towards finding her a suitable donor. Her sister couldn't travel to Iran due to personal problems, and we couldn't transfer her cells from Canada. We searched for match-unrelated donor in Iranian registration bank and found a match-unrelated donor, but he or she also refused to donate cells because of COVID-19 outbreak. And we planned haploidentical transplant from her son, but his family refused to cooperate because he was preparing himself for a national university entrance exam. After 7 cycles of azacitidine, she had an overt relapse in July 2020. And we added venetoclax to azacitidine, and after that, she became dependent to platelet and packed cell transfusion. At this time, transferring the cells from Canada became possible, and so we started salvage chemotherapy and planned for transplant the patient. Now, again, I would like to ask Professor Ravandi, how would you manage the patient after molecular relapse?
Yeah, again, you mentioned gemtuzumab containing, probably gemtuzumab alone or gemtuzumab plus maybe azacitidine. The choice, if you do have venetoclax, again, there's no published data, and our center is embarking on this, but you could use venetoclax plus azacitidine just for molecular relapse, not just for overt relapse. I personally think that whenever you see this molecular relapse, you need to be very aggressive. And I did show you a study from Germany that used azacitidine for patients with MRD positive disease. But as you saw in that study, only 50% of patients converted to MRD negativity. So although azacitidine is an option that we use, it is probably not the most effective option. It's just for a lack of better options. Unfortunately, as I mentioned, there are no established standards for MRD relapse or MRD persistence in AML. In ALL, at least in the US, we have blinatumomab, which has been shown to be effective, highly effective. But unfortunately, there is no such standard in the US or Europe, and for that matter, Iran. So the options are really just gemtuzumab or azacitidine plus venetoclax.
Thank you, Professor. I'd like to ask Professor Kebriai, based on your...
I'm sorry, I can't hear you.
I'd like to ask Professor Kebriai, according to your experience, what is the best strategy for the patient like this before and after transplantation?
So as was just mentioned, I think the patient has very high risk for relapse after transplant. And so we are on clinical trial recommending maintenance post-transplant. I assume the patient is going to receive a matched sibling donor, correct? We're bringing her cells in from Canada. One point I would make is if you were going to do a haploidentical donor transplant, because she's had so many transfusions, I would make sure that she doesn't have donor-specific antibodies, because as you know, there's a risk for graft failure and haplo in that case. If she's getting a matched sibling donor, that's not an issue, but with regards to the risk for relapse, I would consider maintenance therapy afterwards. I don't recall if she was FLT3 positive or not. If she's FLT3 positive, then we would use sorafenib or gilteritinib as maintenance post. There is data looking at sorafenib as maintenance post-transplant. And then on clinical trial, we are using a combination of venetoclax and azacitidine following transplant in patients like this. And, you know,
FLT3 negative.
I'm sorry?
Was FLT3 negative?
Oh, you're breaking in and out.
Was FLT3 negative?
Negative, yeah. So we on clinical trial are looking at a combination of venetoclax and Vidaza post-transplant for maintenance.
Actually, can I say something? I was looking at the chat and I think Dr. Rashidi mentioned something very important. And that's that this patient, I believe, had a history of breast cancer and had prior therapy for breast cancer. So it is very important to remember that even in core binding factor leukemia, patients with AML, therapy-related disease has worse outcome. So this patient, it would have been appropriate once he was in first complete remission and MRD low or MRD negative to proceed with transplant if it was available. We have looked at our own data at MD Anderson and at even our center, the therapy-related core binding factor.
Consider this patient as a therapy-related AML or not, or de novo AML?
I think Dr. Ravandi blocked out again, but absolutely we would consider this patient as therapy-related and high risk despite the karyotype.
Thank you very much.
Thank you very much, Professor Kebriai and Professor Ravandi. Thank you for participation in this webinar. Thank you, our colleagues, for your time. Thank you very much. I hope see in next webinars in title of other than MRD. Thank you very much.
Thank you.
Bye.
Bye.